In this talk, I'd like to focus on some of our attempts to apply mindfulness to individuals with sex-related concerns, and specifically those with sex-related pain. If you haven't become aware of one of the more recent issues of Sexual and Relationship Therapy Journal, I had really an incredible opportunity to guest edit a special issue together with Meg, and also an amazing opportunity to read the wide applications of mindfulness to various populations of individuals and couples with sex-related concerns. So I love this comic because it illustrates really the interpersonal aspects of mindfulness. And in this comic itself, the husband's attempts to explain some of his memory lapses to being more about being in the present. But in all seriousness, the research I've been involved with over the past 10 to 12 years applying mindfulness to sexuality has, in my view, has really had a profound impact on partners. And although all of our application has been with women specifically, whether individually or women who've come to one of our group programs, when we follow up with the women weeks, months, and in some cases years after they've completed the mindfulness-based programs, many of them will share really endearing stories about how their personal journey with mindfulness has impacted their relationship and their partners, and in several cases has ignited a real interest in the practice of mindfulness among partners. And that's been such a delight to be involved with some of that. So I want to talk just a little bit about my own introduction to mindfulness. And this really came about through my training as a psychology resident and then a postdoctoral fellow at the University of Washington, which is located in Seattle in the United States. And I had really the privilege of receiving training from Dr. Marsha Linehan's team using dialectical behavior therapy, which I'm sure many of you in this group are familiar with, perhaps for those who are not. It's really the leading evidence-based treatment for individuals who experience suicidal and other acting out behaviors. It's most common treatment used for individuals with borderline personality disorder. And one of the cornerstones of dialectical behavior therapy is mindfulness practice. And so if you can imagine the experiences of an individual with great degrees of emotional lability, poor sense of self, difficulties with attachments in close relationship, fears of abandonment, etc., and a real sense of profound disconnection with oneself. You can imagine the great utility of a practice that is about embodying one's whole self. And so as a result of Dr. Linehan's work, the module in mindfulness practice has become a core module throughout dialectical behavior therapy. So as a result of being at the University of Washington, I had the opportunity to receive some training in DBT, applied it to the patients I was seeing with borderline personality symptoms and suicidal behaviors, etc. And at the same time, I really still had this primary interest in sexuality, treatment of sexual problems. And it struck me that some of the concerns I was hearing among the individuals with borderline personality disorder really kind of struck a chord with some of the stories I was hearing among the women with complaints of desire and arousal difficulties. And the stories went something along the lines of, women would agree to sexual contact without any sense of motivation. They would sort of go through the act, no awareness of any arousal, whether it be arousal in their mind or arousal in their bodies. Many of the patients I was seeing in the sexual dysfunction clinic had sexual concerns that were secondary to treatment of gynecologic cancers. So cancers that for which treatment involved a radical hysterectomy, including bilateral removal of the ovaries. And many of these women would also report a sense of lack of sensation. So describing receiving touch and feeling touch, but not the associated feelings of pleasure. So their stories really resembled this kind of picture of disconnect. So their body was receiving messages that touch was present. It was not, however, being registered in their minds as being present, pleasurable, etc. So after some conversations with my supervisor, Dr. Julia Hyman, and we talked about the possibility of mindfulness being something that we could apply to these women, and her response was, well, why not? Let's try this. So we did some pilot testing with an eager small group of women, about 25 women, who agreed to take part in a 3-session mindfulness-based protocol that took place over the course of 3 months. So they would come for one session. We would do a fair bit of in-session practice and teaching. They would then go home with a full booklet of instruction, as well as audio recorded guides on mindfulness practice, in addition to a fair bit of educational information on why mindfulness might be useful for some of their arousal and desire concerns. They would come back a month later. We would deepen our practice together. We would add some more layers in terms of the kinds of mindfulness practice that we were doing. And then we would continue on for the next 3 months. And so as a result of some of that really early work, what we ended up publishing was a paper in which we measured not only women's self-report of sexual response, depressive symptoms, sexual distress, relationship satisfaction, but we also brought them into the lab. And the lab, although quite an artificial setting, it was really sort of a neat opportunity to look at how the body responds to sex-related cues. And so the sex-related cues in our case were a series of female-friendly visual erotica that women watched in the privacy of their own room. They inserted a vaginal photoplethysmograph, which measured their genital vasocongestive response. And then we also had them self-report on a questionnaire how subjectively sexually aroused they were. So what we found in this really initial pilot study was that women self-reported significant improvements in several domains of sexual function, not only the primary domains that were of concern to them, in the domains of sexual desire and arousal and orgasm, but they also told us that they reported feeling more sexually satisfied. They were far less sexually distressed as a result. Their mood had improved. Some of their anxiety had decreased. And overall, their sense of well-being had dramatically improved. We also, as part of the study, did some qualitative interviews with the women so that we could hear sort of their firsthand account of how this was experienced by them, this 3-session module. And the feedback almost unanimously across the women was that they felt that among the different ingredients of the treatment, of course, there was the mindfulness practice as the main component, but there was also some education. There was a small degree of sex therapy in terms of talking about the sexual response cycle. But the feedback from women was really that they felt that the mindfulness component was the most useful for them. And moreover, that they felt that many of them wished that they had learned these skills much earlier in their lives, even far before their diagnosis of cancer. Some of them felt that this was a skill that may have helped them in different domains of their life. So we were quite pleased with these initial findings. When we looked at women's responses in the lab, we also found that there was a trend towards improved physical arousal response as women watched their erotic film from before the intervention to after. The effect was not significant, probably because it was a very small pilot study, but the effect size that we found was quite impressive. So what we did with these findings is encouraged by the feedback from women that this might be useful more generally for other domains of their life as well as their sexuality, is we decided to sort of repackage the treatment, expand on some of the mindfulness practice, as well as fold in much more background in terms of mindfulness theory. And also an important change was to do this in group format. We're all well aware of the kind of therapeutic benefits of being in group with other individuals who might be going through the same thing that you are going through, that sense of normalization, validation, support that comes with group, and also stemming from a really large body of literature showing the primary modality in which mindfulness-based cognitive therapy and mindfulness-based stress reduction is administered, and that is in group. So what we then did was we developed a second treatment manual, and this time it was for women who were seeking treatment primarily for their loss of sexual desire. So these were women who said that at one point they enjoyed a much more robust level of sexual motivation, and that had changed. For some of these women, they were well aware of the contributors to that change. In some cases, it was menopause. In other cases, it was a period of severe life stress, changes in relationship, etc. But for many of the women, it was really kind of idiopathic. The causes for their loss of desire were really unknown. So this was a much more heterogeneous group of women than the prior sample that we had pilot tested our mindfulness program with. So this mindfulness program involved now 4 sessions. So we added an additional session, though we kept the general structure in that the in-session time was really about doing some of the practice, followed by some of the background theory in helping women understand the potential ways in which mindfulness might be helpful for their sex-related concerns. There was, of course, some education and some elements of sex therapy, but then really the bulk of practice involved between session daily practice of the mindfulness exercises. So we then published the results of this study, the Journal of Sexual Medicine, and essentially replicated all of the same effects that we had found in our original sample of women who were cancer survivors, in that really all domains of their sexuality was improved, their mood improved, they found themselves to be less anxious, less distressed, and have overall sense of increased well-being. Of course, one of the criticisms from that study is because there was no active control group, the extent to which these improvements were the result of some kind of non-specific therapeutic factor, like being in a group with other women, that sense of support, having a clinician or a physician validate their concerns, etc. To what extent was that contributing to some of their improvements as opposed to something unique and special about mindfulness? So we then replicated that study in a much larger sample of women, about 140 women, where women were randomized to either the active treatment immediately or a 4-month waitlist period. They had repeated all of the same measures in both of those 2 arms. Following the waitlist period, women in the randomized to the control group then received the active mindfulness-based intervention. The results of that study have not been published yet. They're currently hopefully well on their way towards becoming published, but unfortunately I can't provide a citation for that. But I will describe the findings because I think that there's really a very interesting aspect to the finding. So in addition to essentially replicating the main effects in terms of improved sexual response, improved mood, overall sense of better adjustment in the relationship and increased well-being, we also brought women into the lab and repeated our method of looking at just what happens in the body as women are exposed to erotic material. So we did this at 4 time points in women who were in the control group and at 3 time points in women who were not in the control group, so who were in the immediate mindfulness intervention. And one of the things that we were really interested when women came into the lab was the extent to which women's mental sense of arousal, so their arousal in their mind, agreed with their body's physical response. So many of you might be aware of this term as concordance or synchrony. It's the extent to which the body and the mind are kind of in sync, in parallel with one another. So as the body starts to become physiologically sexually aroused, to what extent is the mind in parallel also becoming aroused? Now, many of you, I'm sure, are well aware of the really great work by Meredith Chivers and colleagues that has really looked at this question of to what extent is there concordance between genital and subjective arousal in women versus men. And for the most part, what Chivers finds is that when men are brought into the lab, regardless of men's self-reported sexual attractions, whether they're attracted to men, to women, etc., that their subjective sexual arousal is largely in agreement with their genital response. So as they're watching a film of targets to which they would report being sexually attracted, their mind is becoming psychologically aroused, and the extent of their penile erection increases largely to the same extent. So there's this concordance that happens in men. Well, what we know about women who are opposite sex attracted, mostly heterosexual women, is that there's a very, very low level of agreement, so discordance. In other words, a woman will show a robust physical genital arousal response despite maybe the self-report of not being sexually attracted whatsoever or even turned off by the given film. So Chivers and others have made a strong case that concordance between genital and subjective arousal in women might be an interesting endpoint to start to better understand the mechanisms involved in sexual response in women. And in the case of our mindfulness intervention, it's almost an ideal endpoint to look at, particularly when you think of what we're doing during our mindfulness intervention. So through our practice, we're helping women to redirect their attention onto the present moment, onto the here and now, onto the unfolding of sensations that are happening during a given sexual encounter. And so it might make sense then that following a mindfulness intervention, that there might be more concordance, more agreement between the extent of her mind's arousal and the extent of her body's arousal. So we looked at this. We looked at concordance in women before and after the mindfulness intervention, and sure enough, we found that mindfulness did produce an increase in the amount of agreement between genital and subjective arousal. We also followed up some of our analyses doing what we call some time-lagged analyses, where we were really curious about, well, what's the driver of that agreement? Is it that the changes in genital arousal drive the women's ability to notice them more, or is it changes in her subjective arousal that then drive the agreement? And it turns out that it's the latter. So mindfulness practice, we believe, through the redirecting of attention onto the unfolding sensations, is what's allowing that agreement between genital and subjective arousal to take place. So really exciting findings from our perspective, also because they provide a bit of a mechanism to allow us to share with women about just how we think mindfulness might be useful for some of their concerns. The latter paper, by the way, is also on its way towards peer-reviewed publication. So we also took note of an observation in our findings among the earlier sample of women who attended our group intervention, that there seemed to be a subgroup of women who did better than the other women in terms of their response to the mindfulness intervention. And it was specifically those women who reported a history of sexual abuse. Now, it was only about a third of the small sample to begin with, but those women with a history of sexual abuse seemed to benefit from the mindfulness intervention on their indices of desire and arousal almost twice as much as the women without a history of sexual abuse. So we decided to look at this in a bit more detail. And in a separate study, what we did was we only recruited women who reported sex-related distress that they associated with their history of childhood sexual abuse. And so if you can imagine the experiences of these young victims, these young children, essentially, in the face of this abhorrent abuse taking place, many of them learn to dissociate. Many of them may, perhaps for protective reasons, learn to develop quite an active imagination and go elsewhere while the unwanted physical acts are taking place. So this likely evolved as somewhat of a protective mechanism for the young child as she was experiencing the sexual abuse. So over time, this, in some women, may set the stage for longer-term difficulties with sexual desire and arousal, whereby women may report, even in the face of wanted sexual encounters with a consensual partner and in a safe, supportive relationship, these women will report experiencing, these women will report dissociating, disconnecting, not being present. Certainly not all women, but a fair bit of research has found history of childhood sexual abuse to be a rather significant predictor for long-term sexual difficulties. And so our view was that mindfulness might be specifically useful for this difficulty with dissociation that happened in the face of really wanted sexual contact. So in the context of this study, we recruited women who reported current sex-related distress, again, that they associated with their history of sexual abuse, and we randomized women either to a group mindfulness intervention or to a group cognitive behavioral therapy intervention. As I'm sure many of you know, quite a large literature supporting the effectiveness of CBT and prolonged exposure mechanisms for treatment of post-traumatic stress disorder that's associated with a history of sexual abuse. We administered largely the same batteries of questionnaires that we use in our program of research, and then we also brought women into the lab and looked at this question of concordance, the extent to which the mind's sense of sexual arousal agreed with the body's sexual arousal. So what did we find? Well, we found that actually women in both groups self-reported improvements in their sexual desire, in their sexual satisfaction, in terms of a significant reduction in sex-related distress. So it seemed like there weren't too many differences between the two treatment interventions in terms of their benefits to sexual response and reducing sex-related distress. But when we brought women into the lab and we looked at the concordance between their subjective arousal and their physiological arousal, we found that it was only women randomized to the mindfulness intervention that had a significant improvement in their concordance. In other words, women after receiving mindfulness training and ongoing practice were much more able to become sexually aroused in their mind as their body was becoming aroused. And this happened largely in parallel or in sync with one another. Whereas women in the CBT group, there was no impact on their concordance between genital and subjective arousal. I'm going to shift a little bit now and talk about some of the work that we've been doing in my role in the Department of Gynecology, which is a largely medical, surgical department in a major department, Faculty of Medicine in Vancouver, Canada. And so when I joined the department in 2005, I was sort of a lone psychologist, one of the few PhDs, certainly one of the only individuals whose primary mode of treatment was non-medical. Most of my colleagues, even to this day, are surgeons, physicians who use largely pharmacologic treatments in the various populations of women with different gynecologic concerns that they see. In my role in the Department of Gynecology, I began to see large volumes of women with a diagnosis of provoked vestibulodynia, which, as I'm sure you all know in this audience, probably affects somewhere around 15% of the reproductive age population of women. Women will describe the pain at the vaginal opening as cutting, tearing, burning, stinging. Many of these women will report dysuria or pain with urination, hours, in some cases days, following vaginal contact. For most of these women, in fact, it has a profound impact on their relationships, on their quality of life. They avoid sexual penetration, as well as many other aspects of sexual contact and intimacy, for that matter. It's also associated with a lot of stress, distress, anxiety, mood symptoms, and can be quite a debilitating condition. In fact, there's some health economic data coming out of the United States that find the annual burden of provoked vestibulodynia, once you take into account all the direct costs like medical bills, cost for medications, doctor's visits, etc., as well as indirect costs, time lost from work, secondary disabilities, etc., is somewhere in the order of $31 to $72 billion annually. So quite a major burden of illness with provoked vestibulodynia. And what do we know about provoked vestibulodynia? Well, one theory is that, like other chronic pain syndromes like irritable bowel syndrome, fibromyalgia, etc., that there is a role for central sensitization. In other words, the pain centers in the brains are misfiring. And this is quite a different theoretical view than what used to be thought. It used to be thought that this was a dysfunction that was located really in the pain receptors of the vulvar vestibule itself. And as a result, when you look at early treatments for provoked vestibulodynia, they tended to involve more local topical agents like steroids, like antihistamine agents like cromolyn, etc. And as I'll show you in just a moment, there's not a great deal of evidence for the efficacy. And so researchers have really over the last decade sought to understand, well, what else is perpetuating this pain, especially since on physical exam, there's really no evidence of any tissue damage in these women. In fact, the tissue at the vulvar vestibule looks entirely normal. So researchers started to look kind of higher up in the system, and there's much, much more evidence of central involvement. In other words, brain coordination, brain involvement. And one of the things you can see in this image on your slide here is the inputs into the spinal cord, not only from the vulvar vestibule, but from neighboring structures like the pelvic floor muscles, which are found to be chronically tense in women with provoked genital pain, from the bowel and bladder. And certainly there's evidence that women with provoked vestibulodynia have a much higher incidence of bowel and bladder difficulties like interstitial cystitis, irritable bowel syndrome, chronic constipation, et cetera, et cetera. And so there's much more input kind of going into these sensory nodes in the spinal cord. But ultimately, that much of that activity is orchestrated higher up in the brain. Okay? And so when we talk about provoked vestibulodynia, it really is a brain event. Now that can be a really difficult concept to swallow for women who may have been told, in fact, often are told by their physicians that, well, there's no evidence on the exam, your tissues look entirely normal, this must be in your head, go home and have a glass of wine. And so knowing the sensitivity that these women may have about messages around this may be their fault, this is psychological, this is a result of some kind of sexual inhibition on their part that's under their control, we need to tread very, very lightly when we're talking about PVD as largely a brain event. And I'll talk in a few more slides about just how our group and certainly many other groups have done that. So I want to come back for just a moment to kind of the state of treatment at the center that I work at when I joined in 2005, and it was largely pharmacological. So some combination of perhaps a topical agent like lidocaine numbing cream, most likely an oral medication like a tricyclic antidepressant, as well as an anticonvulsant, whether it was Lyrica or gabapentin. But really, when you look at the existing literature, the evidence for these medications is really not that impressive, despite the widespread practice of prescribing them. And so in one of the only placebo-controlled trials that was done by Foster and colleagues, really a large voice in the field of vulvodynia treatment and research, and Foster and colleagues compared the effects of lidocaine, so again, a local topically applied numbing cream, to disipramine taken orally, to their combination, and against the placebo on women's reports of genital pain. And what you can see in this image here is really no statistically significant difference between any of the treatment groups. And in fact, when you look at the placebo group, it looks like change from baseline in that top graph that it probably did even better, the placebo group, than either to the lidocaine group or the disipramine group alone. And then in the bottom, that graph reflects their actual pain levels on a 7-point scale. And again, you can see the placebo group itself did quite well and really no different from the active medication groups. So, what does this tell us? Well, Foster concluded that the assumption of therapeutic benefits reported by really the majority of previous studies that have been done really must be questioned and reconsidered. And it really, without the presence of these placebo arms, we can't say a whole lot about frontline treatments that are used so widely, medications. So this then provided an opportunity to look at, well, if these medications which are so commonly used in the treatment of PVD are not working, and our understanding of PVD is really a brain-related event, might this be an opportunity to apply mindfulness in these populations? And again, at this point, we had accumulated a growing body of literature showing the usefulness of mindfulness in other areas of sexual difficulties. And so it seemed like a logical next step to apply it to women with PVD. So we also know it's quite well established that mindfulness is also a very effective treatment for stress, and that women with PVD have significantly higher rates of stress, anxiety, and also depression than women without. And in fact, some research showing that higher rates of anxiety and depression will predispose women to PVD. So it's not just a secondary effect of having genital pain, but pre-existing mood and anxiety symptoms can set the stage for a vulnerability to developing PVD later in life. We also know of evidence that reducing stress might influence that top-down regulation of pain responsivity that's really inherent to that central sensitization in PVD. And so that might be yet another mechanism by which mindfulness might be useful for improving the symptoms. A third rationale that really sort of sold us on the idea of applying mindfulness to women with genital pain was our observation, as well as the observation from others, that women with provoked vestibulodynia, certainly not all, but a sizable group of women will frequently report quite high levels of self-criticism, fear of negative evaluation, a concern of appearing just so, and that certain mindfulness practices might really lend themselves well to gently loosening up some of that self-criticism. And so this led us to develop, refine the existing program that we had and really tailor it to the experiences of women with PVD. So our first study that we have published, it's now in press, involved a 4-session intervention, and we have since expanded to an 8-session intervention. And so I want to talk about some of the components of the intervention, because there's much more kind of pure mindfulness practice in the intervention as we're doing it now compared to some of the earlier work where we folded in other elements of education and sex therapy. So following the treatment protocol developed by Zindel Siegel and colleagues in their treatment of preventing depressive relapse in individuals with a history of depression, we followed the kind of flow of introducing mindfulness practice that they have used in the Green Book. So essentially that involves starting with the eating meditation, which we do in session. As you can imagine, for these women who are attending a medical center, expecting to see gynecologists for the treatment of their genital pain, asking them to eat a raisin mindfully, slowly, with deliberate intent can be quite an experience for them. We're often met with puzzled looks, questioning how on earth is this relevant, and our approach largely has been practice first, describe later. And so within that first session, we find that we really draw heavily upon the existing literature which has looked at the mechanisms by which mindfulness changes the brain. So we really frame PVD as a brain event, a brain dysfunction. Of course, it has arms that extend into the body, that has effects on the woman's sense of self, obviously her sexual functioning and on her relationship. But ultimately, if we are to make some headway, so to speak, in helping the woman recover from her PVD, it's going to involve fundamentally changing her brain. By the time we see women in our center, they have been suffering from their symptoms on average, we've found, about 5 to 7 years. They've seen countless different providers. They've tried various medications with limited to no success. And so for many of them, they feel like, well, this is going to be the last thing that they try before they throw in the towel and give up. So even though sitting there mindfully eating a raisin may seem completely disconnected from their experience of genital pain, they're willing participants. And so we find that initial buy-in in the first session is typically quite high. And our attrition rates over the course of the sessions is thankfully very, very low. And in fact, we're able to follow women for months and up to 18 months after they finish. So what I have on the slide here are some of the different mindfulness practices that we've included in our program. So as I mentioned, we start with the eating meditation in session 1, and then we have them practice mindfulness in life for about 10 minutes a day from week 1 to week 2. We then introduce the body scan in session 2. We do a full body scan practice, and we really set the hope that women will engage in daily practice. As facilitators who are both who have both expertise in sexuality and genital pain, but also with our own personal mindfulness practices. And so we quite openly let the women know that we're practicing along with them. We experience the same barriers in scheduling and to-do lists and being distracted that they do, and that we're really in there with them doing the practices at the same time. So we then moved through mindfulness of sounds in session, followed with, again, daily practice, mindfulness of thoughts, the 2 arrows, which we'll talk about in a bit more detail, and a loving kindness meditation, which we'll say just a little bit more about. So the mindfulness of thought is we introduce to women in about session 5 of the 8 sessions, and we sort of experimented back and forth with when is the right time to introduce mindfulness of thought. And we settled on session 5 because we found that it was really important for women to have kind of a solid foundation of daily mindfulness practice with the breath and the body before we then moved towards using thoughts as the object of attention. For many of the women with PVD that we see, we find that this is really kind of a turning point in their deepening of their mindfulness practice, where they will tell us that this is really the point at which they benefit most from the mindfulness practice. And it's so for the following reason. While many of these women will share stories of extreme distress, anxiety, even panic, at even the thought of possible sexual contact. For the single women that we see, many of them will avoid social settings where they might meet a potential partner, again, because in their own minds, they're sort of fast forwarding through what's going to happen after we meet. We may go on a date. There may be some initial sexual contact, and very, very soon after, there's going to be sex. I need to tell this person I can't have sex and tell them why. And so all of this happens really at lightning speed in that moment that the woman finds herself in the social situation that for many of them it leads them to avoid entirely. So this practice of watching thoughts as mental events, not as statements of truth or of reality or as predictions of what's going to happen, but rather something your brain does, is a really valuable aspect of the treatment for them. And again, what we've found is that this is really a point at which there's a kind of a pivotal change. Women really deepen their practice after they buy into this idea and experience the true benefits of the mindfulness of thought practice. Our practices in session tend to be long, and we do that so that we can experience firsthand how to deal with uncomfortable, even painful sensations that come up. And so as you can see in the cartoon here, the amazing transformation of a meditation cushion. At first, all seems well. After 15 minutes, it's feeling suspiciously lumpy. After 30 minutes, it occurs to you that perhaps you're actually sitting on a lump of rock. After 45 minutes, it becomes crystal clear what you are really sitting on. You can see the thorny edges of the soft cushion. And after 59 minutes, it's obvious that you no longer have any legs, so it really doesn't matter. And so we do the extended practice during sessions so that we have an opportunity through our inquiry afterwards to really kind of process what the sensations were like, and can we reframe some of the judgmental thoughts and sensations in a more descriptive, compassionate, neutral way. Now, we've also included in our practice a loving kindness meditation, and we do this close to the end of the program. Those of you who are most familiar with Sindel Siegel and colleagues' MBCT for prevention of depressive relapse will take note that their program does not include formal metta practice or loving kindness practice. And in their view, the cultivation of loving kindness is kind of a natural consequence of many of the other practices like the body scan, mindfulness of breath, mindfulness of sound, sitting meditation, etc., etc. So in contrast, we elected to include more formal metta practice in our program through loving kindness, because we felt it was really important to address the high self-criticism that these women were reporting to us, their sense of extreme dislike of themselves, their standards for themselves, which were much, much higher than their standards that they set for their partner, for other people, for best friends, etc. And so, again, the loving kindness meditation practice is really an opportunity to deliberately practice being kind to oneself. Unfortunately, in the 8 groups, because this comes quite late in the sessions, there's not a lot of time to practice loving kindness meditation. But when we follow up with women 6 months, a year, and 18 months later, they tell us that this was not only one of the most difficult practices for them, but one that they really found to be really quite personally beneficial. We also include what we call the 2 arrows practice. And so what we know is that when people who practice mindfulness are given a painful stimulus and encouraged to just practice on the physical sensations themselves and not on the associated judgmental thoughts or worries about the pain, and trying not to judge the pain, that they actually report less pain. The intensity of the pain is less while practicing mindfulness than without, or in situations where they're focusing on just the qualities, the kind of judgmental aspects of the pain itself. And so this notion that it's possible to separate the physical sensations of the pain, the first arrow, from all of the secondary suffering, the why me, the why is this happening, the anxiety, the sadness, the frustration, the worry, the guilt, the depression, that second arrow, that this might be really useful as a skill for women to practice in situations where they're actually feeling pain. So this is one of the exercises that we actually do in session with women, and we call it the 2 arrows. And it goes something along the lines of what I'm about to read to you right now. And this is a little excerpt taken from our treatment manual. So for those of you who are listening at this point, might be a good opportunity to sort of settle into your seat, get into a comfortable position, one that promotes a state of relaxed wakefulness. If you feel compelled to close your eyes, certainly be invited to do so. If you're afraid of falling asleep, you can certainly keep your eyes open, perhaps slightly open, maybe fixed on a specific target. And take note of the following instructions. So I'll ask you to begin by finding a mild physical pain somewhere in your body. Bring careful attention to the actual sensations that make up the pain. If there's no obvious pain in your body at the present, this might be an invitation to deliberately provoke some pain. And so you can do so by holding your arm up in the air. And you'll note that after holding your arm in this way for some time, that it starts to create some sensations of physical discomfort or pain. You might also elect to sit on your foot, stand, get into some sort of posture that might lend itself to creating a mild physical pain for you for the next few moments as we're here together. So now that you've taken note of the location of this pain, I'll ask that you bring careful attention to the actual sensations that make up the pain. See if you can define the physical boundary of the pain, how far it extends, and what sensations the pain is made up of. Is it sharp or dull? Does the intensity of the sensations making up the pain change over time? Can you notice the very beginning and end of each of the smaller sensations that make up the larger experience? While you are examining these sensations, see if you can notice how the attention tends to want to move away from the pain. This resistance to simply allowing the uncomfortable sensations to exist and be with them in the moment is an example of something that we call aversion at the level of bare sensation. Do not attempt to remove that resistance. Simply pay careful attention to it. And when the resistance disappears, bring your attention back to the physical sensations that make up the pain. When the resistance arises again, pay careful attention to it. Keep doing this, returning to the physical sensations of the pain, and then switching to noticing the aversion to the pain when it occurs. Notice also if there are any follow-on physical sensations associated with the resistance, such as muscular tension, straining, a slight furrowing of your eyebrow, maybe sensations of sleepiness, sensations of restlessness, maybe subtle changes to your breath, as well as follow-on thoughts, fear, wanting to do something to make the pain go away, other intentions. Try to notice all of the physical and mental sensations of wanting to have a different experience. Notice also that aversion, too, is not permanent. Like other sensations, it does not last. Next, see if you can find a pleasant physical sensation in your body and pay careful attention to it. See if you can notice all the various physical sensations that make up the pleasant feeling in your body, and note these sensations in as much detail as possible. While you are examining these sensations, see if you can notice how the attention can have a grasping or clinging quality to it. Notice how there is a desire for the pleasant sensation to continue or increase in intensity, rather than simply allowing the pleasant sensation to exist as it is and be with it in this moment. This grasping or clinging, this resistance to simply allowing the pleasant sensation to arise and pass away is an example of what we call attachment at the level of bare sensation. it can be really useful to get to know attachment intimately in order to be able to recognize it more easily. If you can, focus on the attachment to the pleasant sensation. Do not attempt to remove it. Simply pay careful attention to it. When the attachment disappears, bring your attention back to the physical sensations that make up the pleasant feeling. When attachment arises again, pay careful attention to it. Keep doing this, returning to the pleasant physical sensations, and then switching to noticing the attachment. Notice also if there are any follow-on physical sensations associated with the attachment. Muscular tension, straining, changes in your breath, a slight leaning in, as well as an awareness of any follow-on thoughts. Fear that the pleasant sensations will go away, wanting to do something to make the pleasant sensations stay, wanting to look for other pleasant sensations. Try to notice all the physical and mental sensations of wanting the transient physical sensation to persist. Notice also that attachment, too, is not permanent. Like other sensation, it does not last. With that, I'll ask you to return your focus back to the group, back to the presentation. So that was a bit of an illustration of the 2 arrows practice that we do in session with women. And so, like I've asked you to do here, we encourage women to create a mild physical pain in group, something like holding their hand in the air or taking note of another non-genital pain in their body. But then for homework, we provide them with a recording that we've professionally recorded that invites them to become aware of their genital pain. And so they are invited to provoke a mild genital pain with their hand, or a dildo, or an accommodator, or whatever they wish, just a mild pain, not an extreme level of pain. And then practice observing their aversion to the sensations, as well as perhaps their attachment to other pleasant physical sensations. And so we're watching aversion and attachment as sensations that arise in the body and in the brain, just as other sensations and mental events arise in the body and the brain. So we apply equal emphasis to all of the sensations that arise. So this is a way of helping the women practice letting go, loosening the grip of that second arrow while experiencing pure sensation at the level of that first arrow. So I want to finish this talk just by telling you a little bit about some of our outcome data. In our current trial that's on its way towards being published in the Journal of Mindfulness, we found that while women were waiting for mindfulness-based group to start, that there was a significant improvement in pain self-efficacy. In other words, after waiting 3 months, these women self-reported feeling like they were hopeful about having more skills that they could use to manage their pain. There were no other significant improvements on any other domain through the waitlist period. So as a result of a briefer version of this intervention, not the full 8 sessions, but a briefer 4-session intervention, we found that there was a significant reduction in pain that was evoked during a clinician-administered cotton swab test. We found that women's self-reports of feeling efficacious during sexual contact, during vaginal penetration, significantly improved. We found that the extent of their rumination, and here's an example here, the woman who says, I can't seem to keep pain, out of my mind. You can see quite a significant and clinically meaningful reduction in that symptom. Their feelings of helplessness significantly decreased. Their level of sex-related distress significantly decreased. And there were several other indices of mood, depression, anxiety, global quality of life that also significantly improved. Here's just a brief snapshot of some of our main endpoints, some of our most promising findings. So the mechanisms by which the mindfulness intervention led to improvements in our women is really not fully understood. Ideally, it would be wonderful if we could get fMRI scans on these women to see just how the brain is altered as a result of mindfulness practice. Of course, large body of evidence showing the effects of mindfulness practice on neuroplasticity, on the uncoupling of emotion centers with higher order cognitive centers, with somatosensory centers. We speculate that some of that is happening in our women with PVD, so that when they're experiencing pain, there's less amygdalar activation, less likelihood of experiencing distressing emotions while they're in pain. And of course, we can't rule out the possibility that some of these effects were really indirect effects, given that we know pain is quite responsive to mood, quite influenced by one's level of anxiety and other personality and psychological variables. So it's quite possible that the primary targets of our intervention was really on mood and quality of life. And the improvements in pain intensity were secondary consequences of that. That's certainly one of the questions that we're interested in right now as we have funding to launch a 4-year study where we're randomizing women to an 8-session mindfulness-based group versus an 8-session cognitive behavioral group, which we know there's evidence from Sophie Bergeron's work can be quite effective for women. And we're interested in the differential effects of a mindfulness intervention versus a CBT intervention. We're also really curious about the ability to predict who might do better in a mindfulness-based approach, an acceptance-based approach, versus a more change-oriented approach that is the foundation of CBT. And so these are some of the questions that we're asking in our current study. So we have funding, as I mentioned, to look at 220 women who are randomized to group. They have a large battery of questionnaires. We're following them up to 12 months following the end of treatment. If you're interested, you are certainly invited to read a bit more about our program on the website that's provided on the screen here. So sometimes as a researcher, doing this sort of work leaves more questions than answers. And those lingering questions can sometimes be the source of future studies, future programs of research. And so, again, we're most curious about the extent to which the benefits of mindfulness are specific versus non-specific. Being with other women, being validated, having one's concerns normalized, feeling like you're not alone, like you're not abnormal. We're also really curious to know which of the practices within our variety, our smorgasbord, if you will, of mindfulness interventions is most effective. Is it the meta practice of loving kindness? Is it the 2 arrows? Is it the awareness of body sensations? Is it none? Is it all? And that would be an important question to look at down the road as we may look at exporting the intervention into community sites with, say, community gynecologists who are really the frontline recipients of these referrals of women with genital pain. We also don't know how much of the improvement is due to the natural life cycle of PVD. So there is this kind of ebbing and flowing of symptoms that has been reported. And if we were to just do sort of watchful waiting over time, would symptoms improve on their own? I've mentioned already what are the mechanisms behind which mindfulness is working. Future plans to partner with neuroimaging researchers would really go a long way towards helping us to answer this question. And finally, mindfulness is not for everyone. It's possible that the women who learned early on that this was going to be our treatment approach self-selected out of our clinic, out of our studies. And so are we missing a potential segment of women with genital pain that would not respond positively to a mindfulness acceptance-based intervention? And that's really a question that is quite deserving of future study if we are truly able to make substantial headway towards reducing the distress associated with this debilitating disease. So with that, I really want to thank you all for listening so mindfully during my presentation. Again, thank you to Meg and the organizing committee for inviting me, for allowing me to present to you virtually today.